Welcome back, everyone. And thank you for sticking with us. It's been quite a day so far, and we're going to carry on and I think have a panel discussion that I think will be quite informative and helpful for us as we try to get past COVID or adapt to it or reflect on what that really means for harm reduction and the work that we've done. Frontline service providers have operated under stressful circumstances. It seems certain that many are burned out. And to talk about that today, we are joined by three individuals who know what they're talking about. Ashley Doiron is a registered nurse who has worked at the St. John Correctional Center since 2018. She is joined by Dr. Tracy Meyer, an emergency physician in St. John. Dr. Meyer is an advocate for harm reduction throughout Horizon Health Network. And joining us from Calgary, where it finally is afternoon now, is Jeannette Waegemakers. Her current research includes the psychosocial needs of staff in services for homeless people. We'll be pleased to welcome Dr. Schiff to New Brunswick next month as she will address the Community Advisory Board gathering in Moncton of homelessness surveying agencies and supporters in Moncton, Fredericton, and St. John. But I think I'd like to start by putting to the panel a question. How has vicarious trauma or burnout affected the ability to practice harm reduction? And if I could, I'm not sure if the three have determined a speaking order or not, but perhaps we could I could throw that out to Jeannette, our guest from Calgary first.
Thank you so much, Randy. That's very kind of you. I'd like to perhaps address the question first about all by saying that we're not talking about burnout. Okay, we are talking about people having an inordinately high level of traumatic stress. And so in the national study that we conducted across shelters across 7 different cities across the country, including 3 in New Brunswick, we found that burnout was at a low moderate level, but traumatic stress was at an extremely high level. So if we can correctly identify what we're talking about, and the importance of that is, and I think it's really relevant to everyone who is here at the symposium today, is that people continue to care. When you're burned out, you kind of get disengaged, you check out, you no longer care. But when you're stressed out, the dilemma is that you care, but you can't. And it creates a horrible quandary for workers on the front line who are so emotionally fragmented at this time. And COVID has really exacerbated this inordinately, so that we've all felt it a great deal. The other thing to add to that is that we're really talking about not only, quote, the vicarious traumatization, the way you're impacted by what you hear from your clients, but you're also directly traumatized by what you witness every day. So that the real impact for frontline workers is also, as we've heard from so many wonderful presentations throughout the day, it's what people are witnessing and part of every day, not just what they're hearing about on the sidelines. So I think it's important that we recognize that during COVID, everything has been thrown, as we all know, through a loop, but we've now got the numbers that also support that. I'd like to invite other people on the panel to join me on this as well.
So thank you, Jeannette, for saying that so articulately. And I can definitely add some personal things. I don't think I can actually quite say it quite as well as you did, but I think one of the biggest issues and one of the biggest causes of burnout is actually a desensitization that comes out of pure self-preservation. So when you're constantly seeing awful situations, awful traumas, there comes a point where if you don't let yourself desensitize to a component, it hurts too much. And that's where burnout really initially comes from. And so we see that all the time in healthcare. And I suspect that, yes, COVID has contributed quite dramatically to that. And then the other issue that I'm seeing a lot in both the emergency department, but also in harm reduction clinics is, and this is perhaps it's more so within the emergency department, but there's a treatment of healthcare workers that we haven't had before. And it's something that has come out of COVID, where I would say 90% of the people are still wonderful people and wonderful patients. But there is a treatment that has occurred during this pandemic that has become very harmful. It's difficult to continue being, you know, I don't want to say caring, but it's difficult to go into work every day with a smile on your face when you're being abused. And so I would say for a lot of healthcare workers, there's a component of abuse that has been happening more recently, particularly within the emergency departments, that has made sometimes our own emotions are higher and more strained than normal. And then that also makes it more difficult to be compassionate to others. And so, and we're seeing a lot of that, but at the same time, I do think that it's also been a time where healthcare workers have been trying really hard to collaborate, come together. And along with that, there's been a lot of talk about resiliency, but a lot of the resiliency has to do with just having that collaboration with each other and also remembering where the actual focus should be. So it is definitely a very challenging subject.
Yeah, I definitely have to agree with Dr. Myers, and I know from my personal experience here, there's a lot of suspicion and a lot of hesitation when we, roll out these COVID policies and procedures. And from past experiences, these individuals, their encounters with healthcare providers in the past and their reluctance to kind of accept like what's out there. There's a lot of myths and fallacies associated with COVID. So on our part, like it was a double, you have this increased workload and you're trying to provide for your clients, and at the same time, they're reluctant to accept what you're offering because of all the myths and misinformation that's out there about COVID.
Thank you. Can we unpack that a bit more, Jeannette? Could you tell us about some of the work that you're doing or the research that you have undertaken, and if we can relate this back to harm reduction and COVID? What you spoke of the national study. What are your findings emerging from that one?
Well, I thank you for that, Randy. I'd like to talk about two things. First of all, the national study a little bit, and second of all, an additional local study that I've been doing with one of the emergency shelters here in Calgary that really has been eye-opening in some ways as well. But anyway, in terms of the national study, we wanted to look at the extent to which frontline workers were experiencing either burnout, vicarious traumatization, or direct primary traumatic stress, and the extent to which they continue to have or show depletion of what we call compassion satisfaction. That is, the people remain engaged in this kind of work, which is extremely difficult, trying, emotionally and physically demanding work, because they receive inherently some satisfaction in the process of helping others. And we find that during COVID, people continue to want to help. And I appreciate and recognize and so sympathize with what Tracy was talking about, the struggles, especially for healthcare workers in emergency departments during this period of time. But my research, which was really focused on the frontline shelter workers, who are often involved in harm reduction in many unseen ways, were experiencing these stressors during COVID. And we found that the traumatic stress went up. But I think part of it was also related to a pervasive traumatic stress that we all have felt during COVID. The kind of stress that is precipitated by events that are beyond our control, by being told what to do, where to do it, to having our own mobility regulated, that to create to a sense of not being in control of our own lives in the same degree that we would really want to be. So that's the kind of stress that I'm talking about. But let me flip for a minute and talk about the experiences at the Calgary Drop-In Center, which experienced a tenfold increase in opioid overdoses on site between 2018 and 2021. What I'm talking about now, the Calgary Drop-In Center houses between 800 and 1,000 individuals on any given day. During COVID, they have had to reduce their occupancy within one building and actually rent out some additional spaces so they could continue to provide emergency shelter. They started in 2018 with 18 on-site overdoses in the year. We're talking about a definition of an overdose as when a staff member finds that an individual is unconscious and needs emergency resuscitation, and then EMTs have to be called for transport to hospital. That figure of 70 went to 735 by the end of 2021, so 4 months ago. And in the first 2 months of this year, there've been an average of 300 overdoses per month. So it's escalated exponentially. The stress that this creates on staff is absolutely inordinate, because we know from my research that a lot of staff have minimal training before they enter the workforce, and their supervision, even after they enter the workforce, is coming from people who have been usually promoted because of their longevity rather than because they have additional expertise. So you do have a lot of challenges within the sector. So in terms of a harm reduction, there is a harm reduction that is taking place in these shelters, because I mentioned these numbers of 70 and 735, but out of the 735 resuscitations, I believe that there were only 10 deaths that were reported. So there is a huge saving of lives that's going on. But what's really happened is that, at least in Alberta, with our current rather restrictive government, is that they're unwilling to consider shelters as harm reduction sites. And so there's no supervised consumption that is possible within these sites, even though we know that a great many of the people who are using the shelters need safe consumption sites in order to prevent further overdoses. So we've got this huge quandary going on. And my concern is both for the victims of this restrictive government policy, as both the clients and the staff. I should stop talking, give someone else a chance.
No, thank you. That was very helpful. Already we have a question in for Dr. Myers, and the question is, the increase in poor treatment towards ER staff coming from people who use substances. Is it the family of admitted patients unable to enter, or any specific group? What is your theory for this increase in violence against healthcare workers that is occurring alongside the pandemic?
So I think there's a lot of different possibilities there, and I think everything that you kind of mentioned is perhaps contributing. I think one of the biggest components is actually a mistrust of healthcare workers that's kind of been propagated by some of the thought processes of more fringe thoughts, but definitely there's been situations where people are mistrustful of the diagnosis of COVID. They're distrustful of the policies that the hospital's been putting up. So absolutely, there's a lot of restrictions around who can enter, policies of who can have people with them. And it just creates a situation where all of a sudden you're policing so much more than just health. You're suddenly there saying, no, you can't have family, you can't have items brought in for you. And that's not really a position that anyone in healthcare has usually been put into, that position of having to say things like that, or telling people that no, they're not allowed to leave their homes because they now have this new diagnosis. And these are not things that healthcare workers typically need to tell anyone. I wouldn't say in particular it's people who use substances. And as a matter of fact, I work in the emergency department. I also do have an opioid agonist therapy clinic. And I would say the patients at the clinic have been, there's been really no change in their behavior, and they've been just as lovely as normal. And in fact, they're actually, at times I felt like they actually were looking forward to the appointments, just to have the social interactions. So it's full variety, definitely. But what it has created is, within healthcare workers, perhaps shorter fuses than normal. And unfortunately, oftentimes when you're working with people who use substances, you have to come at the interaction from a point of understanding, a point of compassion. And when, in general, the compassion and the understanding is at a low because of fatigue, compassion fatigue, it creates interactions that are not always as helpful as they should be. And so I would say it's twofold. It's a lot of times the interactions are, everything's two-way. And so people push back what they get. So oftentimes if a healthcare worker is already fatigued and tired and not as compassionate or as kind as they should be, you're going to be presented with the exact same response from the patient. And so it's not necessarily even the patients or the people coming into the department that are the cause of it. Sometimes it's probably our own actual behavior towards the patients that create some of the difficulties. So I think there's a lot of factors.
Are there any particular barriers in particular you can comment on that COVID presented in terms of harm reduction efforts? And I would just toss that out generally. That's a question to panelists.
Well, I'll speak to that one in a few different ways. So from the emergency department point of view, I actually saw more frostbite, more hypothermia this winter than I've seen at any point in my career. And it was interesting because I think the cause of that was due to policies that were actually very well intentioned. And it goes to the situation of shelters. And what had happened was there was this policy that if a patient, or sorry, I shouldn't say, if a person was diagnosed with COVID and was put into a COVID shelter, they were guaranteed that they would not lose their bed at the original shelter. And what that meant was all of a sudden a single person was taking up 2 publicly funded beds in shelters. And all of a sudden there was all these physical beds that had no people in them and all these people that had no beds. And so there were awful storms where people were being turned away from shelters that were half full because the shelters were not being permitted to actually use their physical beds for the people that were knocking at the doors. And so we actually saw quite a few instances of pretty significant trauma, significant hypothermia, and amputations from the frostbite as a result of these policies. So that was really upsetting. The other aspect that we saw quite a bit of was just issues around funding for medications. So I had a number of patients in my clinic who had problems with getting their publicly funded drug plans canceled due to the fact that they took on CERB for a while and it altered their, so I think there was a lot of confusion around how to access different funding, and it really affected their actual insurances. I had a few patients who lost their jobs and they were put into this difficult time period of not having health insurance. And so a lot of patients lost their funding for their opioid agonist therapy, which was, I think, really it was incredibly, I lost a few patients to where they stopped taking their medications. They've since come back, but it has been very difficult for them to be restabilized. Nancy, I think, it's taken care of.
I'm just jumping in at Sarah. Hey, everybody. There's a couple of questions in the Q&A, and I wonder, one for Jeannette from Julia Woodall. I wonder if it's possible that the finding of traumatic stress in the St. John nonprofit workforce may be population related. We have a lot of folks in St. John who grew up in poverty and under difficult living circumstances. We see many folks looking to give back through employment in the nonprofit sector. Were you able to control for socioeconomic backgrounds or experiences of ACEs, adverse childhood experiences, in the workers' lives?
Actually, thank you for that question. That helps me to clarify things a little bit. Yes, we actually asked about adverse childhood experiences. We asked about lived experiences with traumatic events outside of work, but we also asked about people's experiences with experiences of traumatic events as part of their job. And one of the things that we found, first of all, was that St. John, Moncton, Fredericton are not much different than the rest of Canada in terms of the people reporting ACEs. We did not ask about childhood poverty, but we certainly asked about adverse childhood experiences. We asked about resilience. And so we tried to cover as many bases as we could without making people feel as though they were being surveyed to death, so to speak. I can quite clearly say that we can rule out adverse childhood experiences as being a significant contributor to the traumatic stress that people have expressed. What I can also add, and this is something that was interesting and it was totally unexpected. It was the opposite of we expected, that actually shelter workers who were working face to face with clients were reporting lower rates of stress than people who were working from home. So case workers, outreach workers who were not required to be on the floor all the time and who were working remotely and making plans to connect with clients either remotely or by meeting with them in public places because they did need to have some contact. Those workers were actually experiencing greater levels of stress. We speculate that that's because they were lacking the social component that goes along with just being able to get the support from your peers as you're working alongside during difficult times. It doesn't make the difficulty go away, but it helps to know that you're all on the same boat. So those were some really interesting findings. I don't know whether that answers the question or if there's a follow-up question to that I can help to clarify it.
Julia can pipe up, but I think that does answer the question. And to the entire panel, there's actually another question that I'm really interested. I just listened to a podcast on this the other day, actually, and that's the concept of vicarious trauma. And the question that, does it suggest that workers are traumatized by the experiences of people they work with? And can the panel clarify the term a bit more? Because does it paint individuals in needs of services in a negative light, or does it stigmatize them that now they're causing trauma to us, say, or to the workers that they deal with, rather than as folks who are accessing the service and they need it? So now are we blaming them for doing harm to us, I guess?
The thing that we have to remember is that our clients come with histories of trauma. And that we also know that workers come with their own personal experiences of trauma. And in addition to that, 55% of all of the people that we surveyed, and we surveyed about 574 people across the country, so it's a fairly large group, 55% of them that report that this is part of their job. And this is a fact that has received virtually no attention previously, and that is a recognition that that people who are working frontline, and we did not specifically survey people who were just working harm reduction services, but shelters are hopefully harm reduction environments to some degree. So we know that 55% of people are reporting that traumatic events are part of their job. We can't quite separate lifetime traumatic events from job-related traumatic events in terms of saying it's because of the clients. No, I think we have to say in part it's because of the environment in which they work. And what we have to do with that and it's just so simple and it's not been done a lot of the time, is we have to tell people who are applying to work in this kind of environment that it's a tough situation that you're walking into. And it's not one that is, it's not one for which everyone is equipped to work, either by way of training or just in terms of who we are as people. And if we can help people to accept the fact that it is not necessarily an easy place to work, that in and of itself seems to help people to be able to talk about it on the job, and that in turn reduces some of the traumatic stress. It doesn't make it all go away, but reduces it a little bit. So I don't think we can really blame the clients for the fact that they walk in with problems. We just have to help staff to address what their own reactions to that are going to be. Tracy, I think Eric is supposed to be part of this panel, but I think that he got bumped out of Zoom and can't make it back in. I'm not sure.
I'm here, but I don't think I'm part of the part of the panel.
I'm sorry.
I think the onus is on you.
And on Tracy. I'm going to share it with her and Ashley.
And Ashley, perhaps you could talk about harm reduction services that have been impacted for the incarcerated population and what your experience with COVID has been in that regard.
Sure. Yeah. I guess I'll provide a little context about the correctional center. So we house clients that are remanded into custody awaiting trial, or clients that have been sentenced 2 years less a day. So during this time, we at the St. John Correctional Center were designated the COVID center. So any client who tested positive within the province would be transferred to us for care. So consequently, like our preoccupation, or we were preoccupied with COVID this whole entire time. It was all our resources were reallocated to deal with COVID. This meant like some initiatives like the methadone program and the Suboxone program were put on hold. So we would maintain clients coming in if they were on methadone or Suboxone. We'd maintain them at their dose that they came in with, but we wouldn't be starting clients because we just did not have the resources to deal with COVID, as well as start people on the program because of staffing shortages and the extra policies and procedures we had to follow with public health. So it really limited our ability to start people and really like everything was put on hold. We were really preoccupied with COVID, and we continue to be preoccupied with COVID, unfortunately. And like as far as like the stressful side of it, I'd say we're 2 years into this, and I think the most stressful time was at the beginning of this year. So 2 years into this, and it still remains like very stressful time.
I'm wondering if any of you could speak to any long-term ongoing impacts that COVID is going to present for harm reduction efforts. I know that we witnessed a number of lockdowns in our community and in others, and that had quite a negative impact on outreach efforts, on harm reduction possibilities and programs. And I'm just wondering if we can try to get a sense of any ongoing challenges or any long-term consequences that the pandemic has made for us.
I think one aspect of that is just leading up to COVID, there was a lot of momentum in a lot of areas for harm reduction. I think there was a lot of momentum in trying to improve the hospital's policies around harm reduction and trying to make it a safer and more welcoming and accepting place for people who use drugs. And we had all these great things that we were developing, all these policies that we were putting into place. And I would say that was 2 years ago, and it feels like ever since everything's been on the back burner. And I think a lot of things, especially around public health, everything is really on the back burner except for COVID for the time being. And so we've lost a lot of momentum and a lot of programs that I think could have had a lot of benefit for our population. So I suspect that has been quite a significant issue.
And I may add from out here in Alberta that I think in some ways you've been able to maintain your ground better than we have here. And in part it's COVID, but in part it's the political environment. And so we're currently in a political environment that's not particularly inspired by harm reduction and has made efforts to close some of the safe consumption sites. And during COVID, that has been a double whammy because people have fewer resources that they can turn to that they feel that are safe. And even in some of these safe consumption sites, they're now requesting that people provide their healthcare card and identification. We know not everybody wants to do that. I mean, it's really creating a double jeopardy. Even if we decriminalize or try to move away from the criminalization of substance possession, when you're asking people to provide their healthcare information, we all know how badly that goes down. So I would say that it's hard at this point, at least out west, to separate COVID from the UCP. There you go. That's the United Conservative Party in Alberta, which I'm not a particular fan of, as you might gather. So, you know, I don't think we can talk about harm reduction without accepting the fact that there has to be a political will to support these efforts. And without that political will, we're going to be doing a lot of marching in the streets like the suffragettes looking for the vote. I'm sorry, I don't know where that came from, but I think you get the idea.
Important view from Wild Rose Country. Perhaps the local folks from Horizon, can they speak to the lockdowns and the impact that had on harm reduction? And I guess I'm trying to get on what does this mean going forward? What does this if we have to self-isolate again, if we have to get ready for a subsequent waves or more virulent strains of COVID, what does that really mean for harm reduction efforts, and what do we have to do as a community to get ready?
I think one of the biggest challenges during the isolation periods was that I deal with a lot of patients who are in various stages of recovery. And oftentimes during recovery, there's already a very isolating period where you lose your social circle. And that often is a big component of recovery, because if your main social circle is a bunch of people who also use drugs and you're trying to get away from that, you often go through a period where you lose a lot of friends as well. And so a big component of seeing a lot of my patients is actually discussing what are other alternatives, what are options for developing social circles, where can they access just that ability to have that human connection with people again. And when you suddenly go into an isolation and they don't have those options available to them, I saw a lot of isolation in my patients, and it was very challenging for a lot of them. The ones that went into COVID with a good family circle, with a good tight community, they tended to do all right. It was the ones that went in already having issues where they were perhaps losing the social circle that they've had for years. And I mean, oftentimes they get a lot out of those social circles, even if they're not always the most positive influences. And so if you lose those people from your life and then you don't have any alternative options available to you because everything's shut down, it becomes even more isolating. And so I saw some people actually just fully destabilized because they ended up going back to some of the people that they had been with earlier. So I think one thing that's really changed now that things are opening up again is I do often try to have a lot of discussions around brainstorming around what resources are available for people to create new social networks, new friends. There's some really great programs throughout St. John, but those can be precarious due to the isolation that we went through. And so hopefully we'll see that will improve. But again, a lot of the ways that we worked around that are things that require a lot of technology. Right now, this is all technology. This whole Zoom meeting is based on all of us having at least some form of internet access and computers or iPads. And so not a lot of our patients have that. So telling them that they can go to a recovery meeting via Zoom is not very accessible for everybody, unfortunately. And so I think having resources that are not technology driven would be really beneficial. And then also just making sure that there are some things that can remain open, but still keep them at a as clean of environment as possible. I kept my clinic running the entire time of COVID, and I continue to see patients, as many of them as possible, in person. I definitely did some appointments over the phone, but if patients wanted to come in and see me, I never said no. And a component of that was I noticed that a lot of my appointments suddenly became like double in length. And part of that reason was because for a stretch there, I think I was the sole social interaction for some of my patients. Mm-hmm. And I just had to accept that that was going to become a part of my clinic day, was letting it become a bit of social time for the people. And again, in a very clean environment and wiping down all the surfaces in between and wearing our masks. But I think we need to recognize the importance of human interaction in recovery.
Tracy, it's Sarah. Would you even argue that that is actually some of the positive experience that we as clinicians can actually use to sort of combat our own adversity in these situations? Like sometimes it's actually, I don't know, it's almost leveled the playing field because we all felt the adversity of COVID in some degree or another. Is that sometimes sitting down with patients or clients, wherever you are, is sort of, it kind of made your day sometimes. Like it was social for me too.
Yeah, I would definitely agree with that. And when I was talking earlier about some of the issues around burnout, I recognized that I was perhaps discussing more the emergency department, because actually there was often times where I was looking forward to the clinic far more than I was any of my shifts in the emerge, mostly because it was a far more pleasant environment.
But you know what, I'm going to challenge you a little bit, Tracy, about the fact that you mentioned burnout, but you also said very interestingly that your staff continued to be engaged and tried to find ways that you could reach out and do some other proactive things. And I would suggest to you that is exactly what I'm talking about. People were stressed out, but they still cared. They still wanted to be there, even though they knew that they were emotionally exhausted sometimes. And that emotional exhaustion can lead to that kind of angry, frustrated, not doing the best that you really want to do for your patients, but it's not because you no longer give a damn. It's I look at people who are burned out as people who no longer give a damn, but that being stressed out comes from a slightly different place, because it's hard to care and then to at the same time know you're not doing your best because you're so strung out. That's in some ways a much tougher place to be.
Yes. And I'll let you respond, Tracy, but I just wanted to say, and are there lessons learned from that about how to mobilize as a group, how to innovate, how to do business differently? What have we learned from all of this that actually kind of means that we are taking things as a different approach and a different angle, whether that be our own self-care, whether that be how we deliver care? I'd love to think about some of the aspirational things that we think moving forward now that we can leverage.
Really important comment. I think one of the things that we need to remember is that trauma-informed care is not just about recognizing that our clients may have trauma. It's about recognizing that we are all have experiences with trauma and we can all be impacted. That the extent to which our lives are controlled by other people creates usually a negative pushback reaction in most of us. It's no surprising that we're seeing a great deal more civil protests and civil disobedience. I think it's angry people frustrated without a place to vent and deal with that. So recognizing that that this is part of an inherent response, and it may be trauma-induced response, I think it's important. Sometimes if you recognize and can give voice to something, it helps to reduce the burden of it. Doesn't make it all go away. We still need to do the self-care and a lot of other things, but at least we take the elephant out of the room and give it a name and say, okay, we're all subject to this, and we've all been impacted by it in a way that we have not seen in the history of mankind, because this has been universal in a way that we cannot see the universality. And, I think when we're talking about clients, they may have less time, opportunity to really do that kind of reflection, and they need that kind of reflection as well. Anyway, going off, somebody else jump in. Sarah, did you want to add some stuff to that?
Oh, I want to leave space for Ashley and Tracy for sure. So
Okay.
I'll let them respond, and then I'll open my mouth later if I can't help myself.
So I was just going to say, I think there's been, definitely the trauma has been contributing, the interactions, but I think I've also created a lot of good connections with patients around this time period as well. And so there has been just the ability to have longer conversations, the ability to interact. I think there's been a lot of benefit. One thing that actually interesting, I was saying I try to keep the clinic available for patients to come in to see me, but at the same time, New Brunswick is a very rural province. And so one of the biggest barriers that I would often have with patients prior to COVID was getting them to actually come to clinic on a regular basis. And if you try to follow some of the guidelines, there's a certain amount of overseeing that you need to be able to do in order to prescribe safely. And I think a lot of the rules around that have changed a lot during COVID, which has actually opened it up and made it much more available to people throughout the province. I have a lot of patients who live down in Charlotte County, which for Jeannette, if you don't know, that's about an hour away. And for people who obviously can't afford gas in these time periods, that's a very long hour. But then suddenly to be able to have these virtual clinic meetings with them instead of constantly making them come down to see me on a somewhat regular basis, I think it actually has been it's made the clinic more accessible to people as well. So I think there have been some benefits in some of the changes that have occurred due to COVID, and I'm hoping that that does continue.
Well, that's helpful. It's nice to know that there are some parts of this experience that might be of some kind of benefit. I'm just wondering if some of the PTSD or vicarious trauma or burnout that we've talked about, in your opinions, how long lasting is that likely to be? And what can we do to remedy that or to address those consequences that have flowed that we're worried about now? Does anybody have any comment or thought on that? How long lasting it may be, or what the remedy would be for some of that?
Are you asking for our crystal ball, Randy?
Of course, gaze into it, Jeannette. What do you see?
Oh, I think that one of the responses that I can see happening now is as the angst about pervasive COVID has gone down, as we're loosening up, people are feeling a little less being controlled. And I think that reduces the stressful response as well, because part of the stress is out of being involved in a situation where I have no control, I can't fight the enemy, and staying put is about the only thing I can do, which are really classic stress responses. So what I'm thinking of is part of what we're all dealing with, whether it's our clients or ourselves, is what I call a pervasive COVID-related traumatic response. And that as the worry over COVID recedes, it may always be there to a lower level, but we'll be able to cope with it better, and we will at least know that there are some things we can do to help ourselves and help others. that will be good. And I think that the other thing that comes out of that will be also an appreciation of the things we've learned during COVID that are helpful, that we can use going forward, and the things that we've learned that are not helpful. So one of the things that's not helpful is too much Zoom time, because while Zoom is important and it's really helpful, and I agree with Tracy that especially in rural, for people who live in rural areas, that being able to connect over Zoom is better than not connecting at all. And yet we know that in-person connection is also important. So being able to differentially know how much we can do online and how much we need to do in person, so that we have a balance of the two. And I think that that will be helpful too. We'll get a more of a sense back of having control of our lives. And I think that part of the response that we've had is we haven't had the control that we need and we want, that keeps us healthy. So I think that the response will go down, and I think we will come out at a different place. But but exactly how we will all configure that within society is still a work in progress.
Thank you. And do the other two want to take a stab at looking in the future?
I think Ashley, you're about to say something?
Oh, no, you go ahead.
No, okay. I was going to say, it's the whole crystal ball thing is very challenging. I suspect the people that are involved in harm reduction are in it because we love it, because we love the patient population. And I don't think the reason why we're in it is partially because of, you like to believe everything's altruistic, that you like to believe that there's altruistic components to things. But I think there is a component of you're in it because it makes you feel good. It makes you feel like you're helping somebody. And I guess in one aspect, that hasn't actually changed with COVID. And in fact, it's almost been the opposite. I find the differences that we've made in people's lives are even bigger now. And so because of that, I feel like the issues around burnout and vicarious trauma, I agree with Jeannette to come to a big component that actually I feel it less in the harm reduction side of things than I do in the direct, like the standard healthcare side of things. And I believe part of that's just because of the patient population and dealing, and so although there is a component of that, I think people who are involved in harm reduction are still going to be here. I think we're still going to be doing the work that we do. And so I don't think we're going to see it as much on our side as we will in other aspects of healthcare.
Thank you. And Ashley, there was a question that actually has come in for you. Are there any plans to reintroduce Suboxone in the corrections at this time that you're aware of?
Yeah, I think we're still struggling with, like everywhere else, shortages, staffing shortages, but there are plans to start with a methadone nurse. So hopefully that'll come into play here sometime in the immediate future. Again, I think we have 2 vacant staffing spots right now. So once those are filled, we'll be in a better position to reinitiate that program.
Thank you. And we've run out of questions in the chat, and I know it's hard to put people on the spot at a time like this for something like harm reduction and COVID. Last chance to panelists. Any final comments before we sort of wrap up and head to the next section on this?
I just want to say one final thing, and that is we've been talking a lot about the direct service providers and about the clients. We also in the study that we just completed, we also interviewed 42 managers and supervisors in shelter programs. And just to relate it to the COVID situation, one of the things that they pointed out was while there were many challenges in terms of restrictions of services and and inability to provide the harm reduction services that clients needed, et cetera. They also saw it as an opportunity to implement new programs and policies that had been perhaps sitting on the back burner or talked about but never enacted, an opportunity to appreciate more the importance of the work that staff was doing. And so the message that I would like to leave everyone with is that COVID, as awful as it has been for most of us, has created some new opportunities, and we are seeing that people are that there is some value in what we've had to do to reconfigure ourselves to move forward. So it hasn't all been negative.
Thank you, Jeannette. Ashley or Tracy, any final comments?
Tracy, you must admit that we learned that they can create a clinical order set in 48 hours, and before COVID, it took 2 years.
That is true. There is an efficiency to some of the realizing that you don't need to have an in-person meeting for everything. So.
Mm-hmm.
Well, great.
Okay.
Oh, sorry. Did I interrupt? No, I guess that's it. I want to thank the panelists very much for trying to guide us in this conversation about COVID and harm reduction and what it means going forward and really what it's done to us as we've tried to cope with this.